Welcome to the About Bertolotti educational series. If you want to learn about a rare cause of lower back pain that is often misdiagnosed, then you've come to the right place. My name is Matthias, and today we're diving into a rare condition that is called Bertolotti Syndrome. It was first described way back in 1917 by an Italian surgeon called Mario Bertolotti. But despite being known for over a century, it remains a complex and often underdiagnosed cause of back pain. So let's grab a coffee or an ice pack and let's break down exactly what the syndrome is and how to tell the difference between just having weird bones and having the syndrome. First, let's get technical for a second so that we're all on the same page. Bertolotti syndrome originates from something called the Lumbosacral Transitional Vertebrae, or LSTV for short. Normally, your spine has distinct sections. First, you have the cervical spine, which makes up the base of the neck. Second, you have the thoracic spine, which makes up the mid-back, the lumbar spine, which makes up the lower back, and the sacrum, which makes up the pelvic region. As the name suggests, a lumbosacral transitional vertebrae develops at the junction between the lumbar spine and the sacrum. In people with LSTV, there's a bit of an identity crisis at the junction between the two segments. The last lumbar segment does not fully form to become part of the lumbar spine and retains some aspect of the sacral spine identity. Because of this incorrect segmentation, the last lumbar vertebra might try to become part of the sacrum, or in some cases, the first sacral segment might try to separate and act like as the lumbar vertebra. So, what is the result of this? Well, an enlarged transverse process can form, which is the bony wing sticking out on the side of the vertebra, kind of like the wings of a butterfly. Now, here is the most important thing you need to learn today. Having LSTV does not mean you have Bertolotti syndrome. Research shows that having this transitional anatomy is actually quite common. While estimates vary between 4 and 36%, depending on which research you look at, there is a general consensus across several large-scale studies that close to 20% of the population, nearly 1 in 5 people, has LSTV. However, we don't see 1 in 5 people walking around diagnosed with Bertolotti syndrome. So, here's the distinction. LSTV is just an anatomical observation that can be seen on an X-ray or other radiological imaging, whereas Bertolotti syndrome is the clinical diagnosis. This is where the specific bone has been identified as the source of your pain. This distinction is massive because many people with LSTV go their whole lives being completely asymptomatic. Now, the challenge for your doctor is not just finding the bone, but proving that the bone is the culprit for your pain. For a long time, doctors used a system called the Castellvi classification that was developed by Antonio Castellvi back in 1984. However, this classification system has a major problem. It was originally developed to identify disc herniations, not specifically determine whether or not a patient has Bertolotti syndrome. Furthermore, it misses key details like whether the transverse process contacts the iliac crest. In 2023, Dr. Arthur Jenkins and his team sought to address these limitations and thus developed a revised system called the Jenkins Classification. In this system, we have 4 different types of LSTV. Type 1 is where you have the enlarged transverse process that doesn't quite touch the sacrum. There's a gap of less than 10 millimeters, but more than 2 millimeters. In type 1, we have type 1A, where the transverse process of the L5 vertebra, or the last vertebral segment, nearly touches the sacrum on just one side, whereas in type 1B, the transverse processes on both sides of the last lumbar segment are nearly touching the sacrum. Next, we have type 2. This is where there is a pseudo-articulation or a false joint forming between the transverse process of the last lumbar vertebra and the sacrum. This bone-on-bone contact can lead to inflammation and arthritis. There are 3 subtypes of type 2. Type 2A, where the false joint is formed only on one side. Type 2B, where the false joint is formed on both sides. And type 2C, where one side forms a false joint, whereas the other side has a type 1 anatomy, where it nearly touches the sacrum but with a small gap. Next, we have type 3 anatomy, where the transverse processes of the last lumbar segment is fully fused to the sacrum. This anatomy is generally thought to not cause pain at this segment. However, some patients may experience discogenic pain at the disc above. Finally, we have type 4. This is a mix between the different types. We have 3 subtypes of type 4, type 4A, where one side is completely fused like a type 3, whereas the other side is nearly touching like a type 1. Type 4B, the one side is completely fused, whereas the other side has a false joint like a type 2. And finally, we have type 4C. One side is completely fused, whereas the other side is completely normal, meaning that it does not have any connections or proximity to the sacrum or the iliac crest. The Jenkins classification also has a way to capture contact between the transverse process and the iliac crest. However, this detail is not included in this video, but you can read about it on our website or go directly to the publication by Jenkins and his team. Knowing your type is crucial because, as we will discuss in future episodes, the shape of your bone may help guide which treatment approach is best suited for your specific situation. So, you now know the basics of Bertolotti syndrome, but the question remains: how is Bertolotti syndrome effectively diagnosed? This is a surprisingly tricky question. Patients often suffer for years before getting a confirmed diagnosis. In subsequent episodes, we will cover the symptoms associated with the syndrome, the process for getting the right diagnosis, the different treatment options available, and many more. Thank you for watching the first in a series of videos about Bertolotti syndrome. If you found this helpful, please like and share the video. This is the best way you can help us continue to make these educational content and interviews with experts as well as community members. If you have any questions or suggestions on what we should cover next, feel free to leave a comment. Finally, consider becoming a member on the website at aboutbertolottis.org. We provide detailed information and resources on Bertolotti syndrome. You can find the link to the membership page in the description box below. Until next time, keep your posture neutral and stay curious. Thanks for watching.